Good morning, remote attendees. Doing a sound check. Brian, can you hear me? Thank you very much. We'll be starting the meeting in a few minutes. Thank you.
I'd like to call the meeting to order. Ask Secretary to call roll, please.
Director Garza?
Present.
Director Kim? Present. Director Sorrell? Present. Director Webster-Cross?
Present.
Chair Bott?
Present.
And also present remotely is Ms. Merriweather.
Present.
Thank
you.
Thank you. I'd like to entertain a motion to allow Director Cross to remotely participate in the meeting as a voting member.
Make the motion.
Second.
Motion's been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, motion carries. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Friday, April 4th at 9 a.m. Is anyone registered to provide in-person or virtual oral testimony or submit a written testimony to be included in the record?
We did not receive any registrations nor any written testimony.
Thank you. We'll move to the action items. We don't have any appointments or reappointments for Strojo Hospital Department Division Chairs being presented today. We will start with EMS MEC reports and action items. So I'd like to ask Dr. Akin-Torn to present any reports, present the medical staff action items for committee's consideration approval.
Yes, good morning.
Good morning.
All right, so I'm presenting to you a director of the report of our credentials committee as approved by the EMS committee. This is the list of medical staff appointments, reappointments and changes. I want to quickly add that this is my last time of doing this presentation, okay? Because I'll be moving on as EMS president, so somebody will be replacing me from next month, okay? So it's my farewell presentation. Okay.
Thank you, Dr. Akin-Torn. Any questions from directors?
No questions, but actually no
Comments.
question.
Yeah.
You're staying with the system though, right?
Yes. So just
Your
I will not
term-
be medical staff
Term.
president. My
term limit.
4 years, yes, it's over.
Well, I just want to say I enjoyed your presentations. I thought you were always concise and, of course, meaningful in presenting the information. So thanks for serving as president.
Thank you. Thank you.
Thank you, Dr. Akin-Torn, for your service as president. Anything else you'd like to say?
There's maybe I can quickly go through the FYI report of the summary minutes of the HQPS, committee. So those are the highlights there. For emergency department, improved door-to-door discharge time from 400 minutes to 318. Key initiatives: expanded staffing coverage for peak hours, utilization of nursing protocols to streamline triage, data-driven diagnosis focus to identify high delay areas, e.g. dialysis, lower back pain, and tracking admission delays to improve discharge efficiency. Laboratory lab draws by 7 a.m. Target increased from 75% to 80% in 2025. December, there was a dip because of staffing shortages. Critical value reporting, significant improvements in provider read-back time within 60 minutes. Blood culture contamination reduced from 2.5 to 2.3 after extensive education and process improvement. A long-term goal is to reduce that to 1% contamination rate. Okay. Environmental services, bed turnaround time improved from 100 plus minutes to 63 minutes. Coordination with bed control is improving the response times. Pest control response reduced from 18 hours to 3 to 4 hours. Cleanliness scores improved from 55 to 69% in the fourth quarter of 2024. No action items for the EMS, and they are none being presented to you today. Thank you so much. Thank you.
Thank you. All right. Dr. Allegretti, President Provident Hospital Medical Executive, and present any reports and medical staff action items.
Good morning, everybody. I'm here to present the medical staff appointments and reappointments that were approved by the Credentials Committee on February 25th, and then approved by MedExec Committee at Provident on March 7th. And they were submitted to you. I'm here if you have any questions or comments.
Any questions, comments from directors? Thank you.
Thank you.
All right. I'd like to entertain a motion to approve item 3B, Surgery Hospital, Provident Hospital Medical Staff appointments, reappointments, and changes.
Make the motion.
Second.
Second.
Motion been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
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 Opposed? Ayes have it. Motion carries. We'll move to the, thank you. We'll move to the minutes. I'd like to entertain these minutes for February 21st, 2025 were approved at the February board meeting, so it's being presented for the committee's review and discussion if necessary. Any corrections need to be made to the minutes? I'd like to entertain a motion to accept item 3C, the minutes of the QPS Committee Meeting of February 21st.
So moved.
Second.
Second.
Motion has been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
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 All opposed? All right, ayes have it. Motion carries. Move to the operational excellence items, no action needed. These are informational items. Start with, Dr. Turner.
It looks like we've
Yeah,
got
so we
Stroger up
can-
first, so we'll,
Mr. Orders with Dr. Witten.
Yes.
Start with you.
Okay, thank
Okay.
you. Thank you for having me and stepping in for Donica Austin. We're gonna go over our committee, the dashboard. We'll start off with the providers' communication. As you can see above, currently, we're meeting goal for the last 12 months. The provider communication has surpassed a certain percentage that was expected. In fact, we're 4.8% top box above the goal. So far, so great job. There's evidence that the MDs are training with the CI care and the communication that they're doing and the teach back. So great work being done there. As you can see with the nursing communication, good news too. We're currently meeting goals for the last 12 months, and our nursing communication has also surpassed the expected percentage. In fact, we're 6.3 above top box goal, 7% change compared from 2024 to 2025. So great job there with tactics that's being used with the compassionate care training and rounding and visibility that's being done. So good work there. As you look at the mortality index, there's opportunity. We're not currently meeting goals, but we're working toward that goal. As you can see, we have seen a 5.9 reduction in mortality index compared to 2024. And we're still working on some things such as our CDI case review for our ICU patients. We're also doing 100% case reviews and optimizing on the data reports that's received. So we'll continue to do that in 2025, and we'll have more to come. If you also look at the patient safety indicator, we're not meeting the goal, but monthly January performance came in better as baseline, so that's very positive. We're still working toward improvement. You see, we intervened in last year and got a group together. We're showing improvement with the pre and post group with the patient safety cases, which we really did go from 1.12 to the 92 PSI. Some of the opportunities and tactics that we're focusing on, we're focused on reducing the incidence of our post-op respiratory failure and really following on our incentive parameters, education, RNs documenting, making sure that we focus on SCDs to prevent more DVTs. So good work being done, and we'll be updating you as we go forward. As you look at our sepsis bundle compliance, we didn't have our January data, but the physician and nursing groups are meeting to finalize that data, but we'll continue to work on those tactics that we're doing to decrease the lactic fallout, making sure that we follow the orders and optimize on some of our automated reports that we're getting. So more to come when we come back to present. As you look at the readmission, the post-hospital follow-up, currently meeting goal for the 12 months year-to-date, we're below our target, stretching toward a direction of improving. Some of the things that we are doing that we're focusing on is increasing the post-hospital show rate by really working with our patients to come to those appointments by calling them and reminding them. And we're also reducing the allocation ratio of opportunities of appointments that's been given out in certain areas. So more to come, and we look forward to updating you on that one. COPD rate, as you can see, currently meeting the stretch goal for 12 months. We have been meeting our stretch goal for COPD patient readmissions for all the ages and payers. We look at all the payers and the ages that we focus on, and some of the tactics that we're doing is really working on making sure that they get specific diagnoses that contribute to improving that are some of the tactics. Making sure that we refer them to pulmonary rehab referrals and increasing the smoking aids that can help you decrease COPD. So more to come on that. Our geometrical length of stay currently better than baseline for the 12 months, working toward a goal year to date. We've seen a 15% reduction comparing to 2024 and 2025. As you can see, the variance expected with the length of stay. So great work being done as far as improving our discharges, transferring our patients to the SNF and the rehab, but also looking at certain diagnoses that's causing our length of stay to increase and really looking at specific tactics to improve that. So more work to be done this year, but we're celebrating the better than baseline that we've received. ED length of stay to ED discharge, a lot of work is being done around that, this goal. Currently, right now, we're meeting goal for the rolling 12 months, which is good. Year to date, we've seen a 24% reduction compared to 2024 to 2025 in ED length of stay with our discharge patients. So this quarter alone, we've seen a reduction in 115 minutes So that's good news. We've been focusing on the nursing protocol, the triage process, pool to pool, and making sure that we, improve our door-to-discharge time with the low acuity. So more work to be done. We'll be monitoring that for this year. Are there any questions for me?
Questions, comments from directors? Director Cross?
No questions.
Okay, thank you for the information. I think we're, sepsis, looks like one you're continuing to have we'll have updates on.
Yes.
All right, thank you.
Okay, thank you.
Back to Dr. Turner.
Good morning.
Providence Hospital.
Dr. Arnold F. Turner, Chief Hospital Executive, Providence Hospital of Cook County. I want to review the Providence OpEx Committee dashboard with you this morning. Just looking at it at a glance, you can see that there are some areas we have done pretty well in, and some areas we definitely have some room for improvement. And I'll just go over that now with you. Excuse me 1 second. I can't see.
Yeah.
Looking at our patient experience, the survey return volume, we're not currently meeting quarterly volume. Increasing the return of surveys is important for 2 reasons. One, it would better position Providence to be publicly reportable in the patient experience domain for Leapfrog and CMS stars, but also will provide some meaningful data regarding our patient experience so we can identify trends and take actions to make improvements in their experience. The team is working on this by rounding and doing audits on the patient demographics so we can make sure that the patients are receiving the surveys appropriately through the mail. We're also looking at completing, when we're doing the post-discharge audit, we want to meet a goal of 80% of the patients being audited on discharge. And during that audit, call, in addition to checking on the condition of the patient, make sure they have prescriptions, we're going to inquire whether or not, encourage them rather, to complete the survey when it returns. And as this month continues, we should see more surveys return for February, since it just ended. Looking at the nursing communication domain, currently we improved from the baseline in 12-month rolling. We have met our quarterly expected improvement above and beyond year-to-date 2025 first quarter with 11% point improvement. The team is deploying patient communication board and hourly rounding audits with a goal of 80% compliance with the stretch goal of 90%. Looking at left without being seen, we're currently better than baseline for the rolling 12 months. And monthly, we have been meeting our goal. We are at target or below for monthly rates, and in 2025 thus far, and have surpassed our expected quarterly reduction in left without being seen by more than 4 times, reducing the left without being seen rate by 2.62%. The team continues to perform rapid evals and work to lower time between arrival and nurse triage. This is the result of a lot of good collaborative efforts by the providers and our nursing in that department. The other throughput measure that we're looking at is the ED decision to admit to ED depart time. We are better than the baseline for the rolling 12 months and monthly. We're trending down in the ED decision to admit ED depart time better than baseline. We still have work to do in this, but overall we are heading in the right direction. The team in the ED is working on the ED physician bed request to hospital is working on that interval to shorten it, to get the patients up to the room quicker. Also, I want to go back to falls and sepsis. We don't, as with Stroger, we don't have January data yet. That's just recently being reviewed. We'll report out on that next month. With respect to falls, we're currently not meeting the rolling 12 months fall volume, but we have only had 2 falls to date this year at Provident, and I believe last year we had 3 months where we had 0 falls. So a lot of good work is going into that. One of the things we're looking at is decreasing the response time from call buttons and doing hourly rounds to assess the patients and make sure that they aren't at risk for falls. Next slide, please. Okay. Want to look at call attention to our falls. If you look at the monthly rates, that's on the slide, you can see that we have been definitely below target each month, and the rolling 12-month rate, I'm sure over time will reflect the work that we've been doing. That concludes my report. Any questions?
Questions, comments?
Very
Great.
good improvement on the left without being seen. I know that's been an area that you've been working on.
Thank you.
Yeah. All right, thank you. We'll have Craig Williams about the CCHN site review.
Good morning. Craig Williams, Chief Administrative Officer, Operations and Development, here to talk about our ACHN OpEx work. So focused on the patient experience, right now our highest level goal is staff work together. That's our biggest opportunity to move our overall likelihood to recommend scores. And we're currently not meeting that goal in the rolling 12. However, our monthly is coming in better than our baseline performance. Year to date, our expected improvement for Q1 was 0.6 top box percentage increase, and we're just not at that point yet. We're really focused on working on kind of the transitions from from the waiting room to exam room, and really having the clerks talk through that process around what's happening when we have delays, being really open around that. We're also, Lynn Dang's team is working on defining what the patient experience is for each clinic. And then at a high level, from a leadership meeting, we're also hitting on key themes each month specific to this. So we're hoping to see some progress on this goal. The next two are around provider work. And so for top box provider addressing concerns and worries, we're currently better than baseline for the rolling 12 and monthly. We've reintroduced our compassionate connected care model, which I think is affecting both of these scores, which are seeing strong results. Year to date, our expected improvement for Q1 is on track with a 0.3 percentage point improvement. What we are seeing continued improvement month to month, which is bringing our rolling 12 score up, which is really, really good. And I think really focused on that compassionate connected care. On provider explains the problem condition, we're currently better than baseline for our rolling 12, and we recently came in at goal monthly. Like I said, we've reintroduced the compassionate connected care model. Year to date 2025, our expected improvement for Q1 surpassed the expected improvement of 0.48 percentage points, and we're currently 1.2 percentage points over our Q1 improvement. So we'll continue to work on that, but seeing some early results there. Within our HEDIS results, so on breast cancer screening, we're currently meeting our stretch goal. Our breast screening rates are above target at this time. We've surpassed our quarterly expected goal thus far through January, February 25. And we've exceeded our Q1 improvement expectations year to date. On hypertension management, we're currently not meeting that goal, and we've basically stayed at baseline. And so we're reworking with both our care gaps team to address that miss year to date, as well as engaging with the medical directors on their particular scores for their clinics. The last one is around empanelment, and we're, again, currently better than baseline. We're trending upwards in our patients that are engaged or affiliated. Just to remind everyone, we define that as patients that are seen 2 times by the same PCP in 2 years, or seen at a PCP clinic one time in 2 years. We're about 586 patients away from meeting our Q1 expected improvement goal. So I think the biggest thing we've done here is really around improving access to our clinics. We're working on another related goal around the % of patients that we see within 14 days. And we were doing surprisingly well on that goal. And what we realized is that what I realized is that we had capped our schedules. So we're only opening our schedules 14 days out. So we truly weren't scheduling any new patients greater than 14 days. However, when patients called and there wasn't room in the schedule, we were asking them to call back. So we brought together a multidisciplinary team, and we were initially going to increase that to a 30-day opening in the schedule, but hope to we're going to continue to monitor how many people we can't fit into that 30 days with the goal of expanding that. The reasoning that we had capped at 14 days was really to improve our show rates. And what I tried to remind the team was, well, if patients can't get in, they're not showing at all. And so let's not, cook the books for one metric and then kind of close the door on access. So I think it was a really good discussion. I think we made some immediate changes. I think we'll continue to make changes to that.
Craig, is there like a urgent care or space for people that might need appointments?
So we did launch this year our Express Care, which is virtual urgent care. So that is in place. The volumes there are not where we want them to be yet, but we continue to market it. We're also working to get that into our flow in the call center. So as people can't get into an appointment, we give them that option to go virtual. We're also working on opening an urgent care expansion at Arlington Heights. So that would be kind of using that same space but extended hours with APPs to be able to provide that urgent care to that market to kind of test proof of concept there. And we actually have an opportunity likely at Belmont Cragen with our new arrivals clinic ramping down. We'll have space to we had originally considered urgent care in that location. However, with that clinic, we didn't have the space, but now we'll have that again. So,
Greg, what was the what was the no-show rate before you made the change to 14 days? And how did it improve when you went to 14 days?
So virtually this change happened within the last 2 weeks. We brought everything together.
But you said the staff were concerned that the no-show rate went up.
I think what we've seen historically is that when we book patients farther out, and this is a national thing, that patients are less likely to show.
Yeah.
We've put a lot of tools in place to ensure that, but generally, our show rates are about kind of in between 80 and 85%, depending on clinic. So, with our patient population, there definitely is a challenge on show rates that we continue to work through.
I have a question about your breast cancer screening rates.
Yes.
It seems like there's over 4% point increase in January and February. Were there new interventions you implemented?
Yes. So related to the Cook County screening program, which Commissioner Lowry sponsored, we put a lot of focus on both prostate cancer screening and breast cancer screening. We've been running patient lists. So we're trying to organize around both. So two things. Residents of Cook County can call and get a free cancer screening during the month of their birthday. And we're not seeing a tremendous amount of calls for that actual initiative. So we've, in conjunction, to meet the spirit of that, we were also running lists based on our current and panel members' birthdays and doing reach out to get them in to schedule their mammography and prostate cancer screenings. And we've expanded hours specifically in mammography to be able to do that. So we've expanded Saturday hours, and we've expanded some of our community slots too.
Thank you.
Sure.
All right.
Thank you.
Any other questions? Thanks for, and good to see the breast cancer screening rate. We have a regulatory and accreditation update by Joseph. morning.
Just some regulatory updates. Joint Commission survey at Providence, we had an assessment visit on March 4th. Did receive our report and we're working on action plans currently. Regarding preparedness, we did a mock stroke for survey, stroke prep back on January 30th and 31st, produced a report and an action plan as far as some deficiencies. Stroke leadership completed the deficiencies, and so that has been, that hole has been closed, and we continue weekly with tracers as far as preparedness. We're actually on our 5th week, and I'm going later this morning. National patient safety goal posters are being distributed now, and again, it's about patient safety on the units. We'll continue in the coming weeks. As far as imminent surveys, we are waiting on IDPH for outpatient dialysis, expected at any time. And as far as preparedness, we've been rounding since December, and I just rounded yesterday, and we're rounding roughly about every other week, just to make sure they're still in good status. Next slide. Imminent surveys continued. We have a Joint Commission primary stroke. The window opened January 10th. It's open till April 10th. And I was just looking at the calendar. So we're looking at sometime in the next 4 weeks. Because it's semi-unannounced, meaning they're going to give us a 7 business day notice, that kind of rules out next week. So roughly 3 weeks is the window between now and April 10th. So again, preparing on that on a weekly basis. Upcoming surveys, we got a number of them. We've got Joint Commission Healthcare Equity. Preparation is currently underway and has been. We're planning, I have a plan ready of June 10th. We've got American College of Surgeons Bariatric Accreditation. This will be a virtual survey. Preparation is also underway. The planned survey date will be July 11th. We've got American College of Surgeons Trauma Center. Again, preparation is underway. We have a planned survey date of August 13th and 14th. 2-day survey. It's also a virtual survey through American College of Surgeons. And we've got lastly IDPH EMS Resource Hospital site visit. We're looking at a ready date of sometime late fall 2025 or early spring 2026. We're just waiting on some equipment updates that are expected, and then we will be good to go with that. That's all I have currently. Can I answer any questions?
Questions, comments? No. Anything we can do to support any of these activities?
You know, I think we're doing pretty well, but I absolutely will bring it up if we need anything. I appreciate it.
Thank you.
Thank you.
Thanks for keeping us updated. All right. The committee will not be going to closed session today, so if there are no other questions or matters to discuss, we can move to adjournment of the meeting. No. Director Cross, good. Okay, we declare the meeting adjourned.
Thank you.
Thanks. You were. All right.